Good morning again, everybody. Good morning.
Good morning.
It's good to see all of you all this morning. This is an extremely happy day for the Legislative and Public Affairs team at the National Minority AIDS Council and myself. This is the culmination of 3 years of work that has really been a labor of love for many of us. We've gone across the country and combed the depths of the literature for some meaningful conclusions to share with you all today to hopefully make at least a beginning conversation advance, starting to look more upstream at those social and structural causes that enhance HIV vulnerability among Black, gay, and bisexual men. At the end of today's meeting, we hope that you'll walk away with both an enhanced understanding of the work that we did together, but also know that this is the start of many conversations to come and is only the beginning of much more, hopefully, value and enriched work that this work will be a part of. I have the pleasure of introducing Ernest Hopkins, who is, amongst many other things, a well-respected and long-served servant in the HIV community and public policy and advocacy. He's currently the legislative director at the San Francisco AIDS Foundation in San Francisco, California, and serves as the chair of the National Black Gay Men's Advocacy Coalition and the Communities Advocating for Emergency AIDS Relief Coalition, CARE Coalition. And he will be our MC for today. So without further ado, invite Ernest to the podium.
Thank you, Kali, and thank all of you for turning up this morning for this very exciting event. I think Kali said it well. This project has really been a great opportunity and a labor of love amongst a number of folks who would like to work more closely together, but time and space limitations don't allow us to, and so it was really very fruitful for us to be able to have the time and the opportunity to gather ourselves together with so much wonderful data that's been prepared by the researchers and pull together this wonderful report. So without further ado, let's get along with the show. Our first speaker this morning will be Dr. William L. Jeffries, who has received his Master's of Public Health and Social and Behavioral Sciences and his PhD in Sociology from the University of Florida. His research focuses on the intersections of sexuality, race, and ethnicity in relation to HIV infection among American men. Dr. Jeffries has worked for the Centers for Disease Control and Prevention, both as an epidemic intelligence service officer and an epidemiologist. In his current CDC assignment, he leads research addressing social determinants of HIV infection among Black, gay, and bisexual men, and Dr. Jeffries was a recipient of the McKnight Doctoral Fellowship and has published in a number of academic journals, including the American Journal of Public Health and the Journal of African American Studies. Dr. Jeffries, without further ado.
Thank you, Mr. Hopkins, and thank you all for coming to this momentous event. I'm gracious to be here representing the Centers for Disease Control and Prevention, where I currently serve as a research scientist in the Division of HIV/AIDS Prevention. I'm extremely grateful to my dear brother in the struggle, Mr. Kali Lindsey, and all my sisters and brothers at INMAC for the leadership on this important effort. And the title of this talk is Black MSM, HIV, and the Social Determinants of Health Imperative. And at the Centers for Disease Control and Prevention, we are definitely believing that it's imperative for us to address social determinants of health that underlie many of the health problems that Black MSM and other vulnerable populations face in the United States. And so what I'll be doing today is talking about social determinants of health that we believe are most relevant for Black MSM in the United States, but also giving some guidance for interventions that might be effective in addressing this problem of HIV among Black, bisexual, and gay men. And I'll be remiss not to acknowledge the substantial contributions of my colleague and friend, Mr. Greg Millett. And so an overview of this presentation, I'll be spending a brief amount of time overviewing some of the knowledge we have regarding HIV infection disparities among MSM in the United States, And then I'll proceed with a discussion of social determinants of health. First of all, characterizing what we mean by this term, social determinants of health, and then spending some time talking about homophobia, racism, and socioeconomic status, which are very important in understanding the epidemic among black, bisexual, and gay men. You'll notice that throughout the presentation, I'll be alluding to findings from a recent meta-analysis of 194 studies, which I had the fortune of working on with Mr. Greg Millett. And in this meta-analysis, we essentially combined data from 194 published studies that comparatively assess structural, clinical, and behavioral factors among black and non-black MSM, findings which are relevant for today's conversation. And then I'll conclude discussing intervention strategies that might be effective in addressing the undercurrents of health and social problems that we find in our population. For those of us in the room today, it's certainly no surprise that we continue to see stark racial disparities in HIV infection among MSM. And in our recent meta-analysis, we found that the odds of HIV infection were significantly greater comparing black and non-black, mostly white MSM. Overall, the odds of infection we found to be 3 times greater for black MSM, with the odds of infection for young MSM comparing black and white MSM being about 5 times greater for black MSM. We also looked at the odds of having undiagnosed HIV infection among MSM, and we found that overall the disparities were even greater, with black MSM having an odds of about 6 times greater than white MSM, and young black MSM having an odds of about 7 times greater as young white MSM. And certainly we're aware of what undiagnosed infection and the high prevalence of undiagnosed infection in our community means for ongoing transmission of HIV. But then there's this problem with increasing incidence or new infections of HIV among young MSM and young black MSM in particular. And increasing infections provide us a grim picture of what HIV prevalence will look like in the relatively near future. Using existing data, Ron Stahl and colleagues estimated that by the time young black MSM, a 20-year-old cohort of black MSM are 35 years old, we can expect about half of these men to be infected with HIV. And given what we know about the prevalence of HIV being relatively high among older black MSM, this suggests that within a very, very short period of time, perhaps even only a few years, we can expect the majority of black, bisexual, and gay men in the United States to be infected with HIV. Of course, one of the overarching questions we've been asking ourselves is, why do we see not only these stark racial disparities in HIV infection, but what we are perceiving to be this worsening epidemic among black MSM? And could it be that black MSM are suffering with this ill of HIV because we are perhaps doing something that is causing us to be in this state? Actually, we've spent a lot of time assessing racial disparities in HIV infection, looking particularly at behaviors that can transmit and result in the acquisition of HIV. And we found that these disparities are not due to risk behaviors. In fact, in our recent meta-analysis, we found that black MSM indeed had a greater likelihood of engaging in condom use, having few sex partners, avoiding substance use, and engaging in repeat HIV testing. So there's something else going on here that we not only need to understand, but need to address as we move forward. And the only way we can fully understand this problem of HIV and these disparities that we're observing is to understand the social determinants of health. And what I'm going to do now is avoid a drawn-out discussion, academic discussion regarding what social determinants of health are. And I'm going to make this plain for all of us in the room. And I want you to take a journey with me. And I want you to imagine visiting a local gardener. And here you find that she has some flowers that are dying. To understand why, you expect the flowers soil and discover that they have not been fertilized, haven't been well watered, and have been confined to pots that have not allowed their roots to expand and absorb healthy soil's nutrients. Moreover, the gardener placed these flowers in a shaded area that receives little sunlight to spawn the flower's growth. And then you visit another part of the garden, and you find flowers that have exceptional blooms. You examine the base of the flowers and find that they have been well watered, well fertilized. And unlike the first flowers, these flowers were planted in the ground directly so they can readily absorb the soil's nutrients. and the gardener placed them in a sunny area of her garden in order that they can flourish from year to year. Your visit to the gardener makes it clear that she provided conditions to the second group of flowers that not only made them be able to be healthy, but provided conditions for them to thrive. And given the scientific evidence, that's what we mean by social determinants of health. Sir Michael Marmot and many others have done lots of work demonstrating that social determinants of health are factors external to individuals, but most important in shaping health outcomes. And we now have a vast body of research going back centuries that illustrate that the fundamental causes of health problems are social and not primarily due to individual level risk behaviors. And in the previous example, it was clear that the gardener's treatment of the second group of flowers resulted in conditions that allowed those flowers to be healthy. And similarly, for oppressed groups like MSM and Black Americans in the United States, we know that these groups suffer ill health due to unjust treatment as a result of living in an unjust society. And so for Black MSM, given the research we've done, we know that homophobia experienced within society, as well as racism and low socioeconomic status, are very relevant in understanding HIV among Black MSM. What do we know about homophobia? Well, in 2010, Sarah Glick and Matt Golden did a study in which they reported that 55% of Americans still believe that homosexuality is always wrong. Well, why does attitudes toward homosexuality, why do these attitudes matter in terms of HIV? Well, we have research that has demonstrated that homophobia experienced by Black MSM can independently predict the promotion of sexual risk behavior among Black MSM. In fact, I was lead author on a study with CDC in which we found that experienced homophobia independently predicted behaviors that transmit and can result in the acquisition of HIV infection. And because homophobia results in negative attitudes toward bisexual and gay men, it can also produce an inadequate public health response to HIV for Black MSM. Let's also think about racism. And in the United States, we live in a context in which race-based mistreatment is prevalent, with one of the most common, most prominent examples being the mass incarceration of Black men. And if you have not read Michelle Alexander's book, The New Jim Crow, I encourage you to do so. She provided a very exceptional and historical account of how the mass incarceration of Black men in the United States is not only evident of racism, but in many instances suggestive of ongoing race-based mistreatment that Black men in particular will suffer. And racism matters for us in public health because we know it contributes to the promotion of multiple adverse HIV-related outcomes. In 2012, George Ayala and colleagues found that experiencing racism was independently predictive of sexual risk behavior among Black MSM. Fisher Raymond and colleagues, using data from San Francisco, have shown that racism results in the access can result in Black men's access to relatively high-risk partner pools, and this access is a product of the historic segregation based upon race that we have in the United States. In another study, Laura Bogart and colleagues predicted over time that experiencing racial discrimination was associated with non-adherence to antiretroviral therapy. So racism matters in terms of the outcomes we're concerned about in this epidemic. But then there's also low socioeconomic status, in particular poverty. And if you read any introductory public health book, you'll find that poverty is the #1 determinant of health status in populations throughout the world and throughout social contexts. In 2010, the United States Census Bureau reported that Blacks are nearly 3 times as likely to live in poverty as whites, 35% versus 13%. And in our recent meta-analysis, we found that Black MSM had a significantly greater odds of having less than a high school education, of having low income, ever being incarcerated, and currently being unemployed. And so you may wonder why these outcomes matter when we look at why socioeconomic status matters when we're looking at outcomes that we're concerned about in terms of HIV prevention. Well, in our meta-analysis, we were also concerned about low income in relation to an HIV treatment cascade, comparing Black and white MSM. And as I reported earlier, in terms of having an HIV-positive diagnosis, Black MSM had 3 times greater odds of having an HIV-positive diagnosis. But we found that black MSM had approximately half the odds of having ART use, about half the odds of having ART adherence, and about half the odds of having viral suppression. We also found that black MSM had about half the odds of white MSM as having health insurance, and we know that health insurance is important in providing people with potentially access to care. Again, black MSM had about twice the odds as white MSM of having low income, and we know, given a host of studies that have been done, that low income is predictive of these outcomes. So these things matter for black MSM in the United States. Certainly in public health, we're interested in not only understanding fundamental causes of health problems, but also doing something about it. So I'm going to spend a few minutes talking about potential intervention strategies that we have. And we're very fortunate now that the federal government, under the leadership of the Obama administration, has launched and supported multiple efforts that can fundamentally change the social contexts in which we as black and other MSM in the United States live. For example, attempts to repeal the Defense of Marriage Act might be beneficial in terms of not only providing marriage to black MSM in same-sex partnerships, but also normalizing partnering within our community such that black MSM who might be at risk for acquiring HIV by having a high number of sex partners might avoid that risk if we can make marriage something that is at our disposal. Certainly, many jurisdictions throughout the United States are beginning to understand and wanting to intervene on social determinants of health. And local efforts have certainly addressed issues related to poverty and racism. It's interesting that a lot of the efforts now are addressing anti-homophobia acts. And I highlight here Milwaukee's Acceptance Journeys campaign, which is relatively similar to the I Love My Boo campaign in New York City. Both of these are mass media social marketing campaigns that wish to not only normalize the lives that we as black MSM live, but also address homophobia at its root. So the notion is that we're not going to intervene on people who are already vulnerable to HIV. We're going to address the reason why they're vulnerable to HIV by changing the context in which people live. We're currently in the process of evaluating acceptance journeys to see if it's effective in changing homophobic sentiment over time. Recently, the U.S. Department of Health and Human Services funded the Care and Prevention in the United States, or CAPAS demonstration project, which is with CDC in terms of leadership now. And this project is being funded during September 2012 to September 2015. And what we've done is awarded about $44.2 million to 8 state health departments. And in our funding opportunity announcement, we mandated that state health departments must address social determinants of health that place racial and ethnic minority individuals at risk for HIV infection. All of these state health departments are doing work with racial and ethnic minority MSM, and some of them are indeed trying to address social determinants of health that place racial ethnic minority MSM, in particular black MSM, at risk for HIV infection. One good example is that in Illinois, we are launching an initiative to promote access to care and provide vocational and educational training to young black MSM. So as we think about ways to move forward, IMAC's recent publication with Kathy Malsby provides additional confirmation that we urgently need interventions that promote linkage to care, retention in care, as well as adherence to antiretroviral therapy, because we know these things impact the health of black MSM. But given what will be released in today's action plan, and given the vast body of scientific literature on social determinants of health, it is also important for us to address the social undercurrents of risk for black MSM, and in particular homophobia, racism, and poverty, to change the context in which we live, to provide healthy environments so that black MSM can reap the benefits of good health, like other populations do. For those of you who may be interested in readings on social determinants of health, I've provided some references that you may find useful. Thank you.
Thank you, Dr. Jeffries, for that very excellent talk. And now more of the same from Dr. David Holtgrave. Dr. Holtgrave is very well known to our community, and his research is focused on the effectiveness and cost-effectiveness of a variety of HIV prevention and care interventions, including the provision of housing as a structural HIV/AIDS intervention. Thank you very much for that. And the relationship of the findings of these studies to HIV prevention policymaking. He has served on an Institute of Medicine panel charged with recommending methods to improve the public financing and delivery of HIV care in the United States. He has also previously served as the director of the Division of HIV/AIDS Prevention, Intervention, Research, and Support at the U.S. Federal Centers for Disease Control and Prevention. And he's also investigated the relationship between social capital measures, infectious disease rates, and risk behavior prevalence. He's worked extensively on HIV prevention community planning and has served as a member of the Wisconsin HIV Prevention Community Planning Group. Interesting, I didn't know that. And aren't you still on the Presidential Advisory Council on HIV/AIDS?
At this moment.
At this moment.
Thank you.
Dr. Holgrave.
Thank you so much, Mr. Hopkins. It's terrific to be on the panel with Ernest and with Dr. Jeffries this morning, and also really wanted to thank the Ford Foundation and the National Minority AIDS Council for allowing us to work in partnership on this incredibly important initiative, and it's been terrific to work with Mr. Lindsey and Mr. Quata and Daniel Montoya and all of my other friends at Unmet. It's been a real team effort, so thank you very, very much, and thanks for including us. So I'd like to talk a little bit this morning about the project that we did in partnership with NMAC, and there were really three important parts to this, and I'll spend most of the time on the third part. So first we were asked to examine the literature and the epidemiology around HIV/AIDS among black, gay, and bisexual men with a focus on social determinants, and also to look at what interventions were available in terms of prevention and access to care and treatment and adherence, and then also to take the information that we found and try and look at what unmet needs are there among communities of black gay men in the U.S. If we wanted to provide all of the prevention, care, and housing services that would be necessary to at least meet the goals of the National HIV and AIDS Strategy, what kind of new or redirected public or private sector investments would we need to be able to do that? And I'll go very quickly through the first two of those aims and spend more of my time, I think, on the third, in part because I think the first two aims very nicely complement what Dr. Jeffries has already presented. So this first aim resulted in a paper with Kathy Malsby as the lead author. Greg Millett was kind enough to join us, and with Kelly and Daniel and others from NMAC in partnership. And this just came out in AIDS and Behavior. And in this particular project, we wanted to, again, look at the epidemiology and social determinants of health among black MSM. And you'll see that I'm sort of switching terms now instead of saying black, gay, and bisexual men, which I would prefer to use as terms. But in the literature, in the research literature, black men who have sex with men or black MSM is much more the term that's used and that the studies often use. So to be accurate to the literature, I'll kind of switch and say black MSM. So we looked extensively in the literature, a lot of different databases that were searched to try and find everything that we could. And we wanted to focus especially in the search on black MSM and then cross that with areas like behavioral, biomedical, structural, social, contextual, psychosocial, and social networks. And when we got done sort of combing through lots and lots of literature, there were about 39 really key papers that we wanted to review. And some of the key findings, and again, I'll only do a couple of slides on each of these first two papers, but one, again, is to underscore the message that when we looked at the literature, we can't explain the health disparities around HIV among black MSM on the basis of differences in risk behavior or circumcision. That's not the driving factors. And also, when we looked at the literature on incarceration, discrimination, stigma, social isolation, and mental health, what we found was a relatively inconclusive literature, not because these aren't important factors, but rather when we look at the complexity of studying these factors, we don't find sort of as crisp of a literature as we might like in terms of very, very clear findings. And so you'll see on the next slide, I think an important area that we wanted to call for more research in is really understanding the complex and intertwined areas of incarceration, discrimination, stigma, social isolation, and mental health issues. There needs to be a lot more in the way of federally funded and other research that focuses on these important social determinants of health areas. This is a new and growing arena. Also, thirdly, we found that there was a heavy peer support in studies around condom use among black gay men. And that, of course, is an important resiliency. And one of the things I think that's really encouraging in the literature is that, thanks to Ron Stahl and others, we're switching from thinking in the literature of kind of challenge models to more resiliency models. And what are important strengths, what are important assets, what are important resiliencies. And so wanted to highlight that peer support for condom use is important. But that also when we think about, well, what are the research-supported drivers of the health disparities and HIV among black MSM, it seems like high rates of STDs, other STDs besides HIV, high rates of undiagnosed HIV infection, lower access to heart use and adherence services helps to explain some of these differences by race. And then in terms of conclusions, again, I already mentioned that we think there needs to be this call for more research on social determinants of health. We think that this trend toward focusing more on resiliencies is an incredibly important one and needs to have further work done. And also that there needs to be more research done to understand barriers and facilitating factors around HIV and STD testing, linkage, and retention and care. So that, of course, was the first step to try and look at what do we know about some of the challenges and some of the determinants of these disparities. The second was to review what are some of the literatures, what do we know? And this paper actually is now accepted and coming out in BMC Public Health, hopefully in a few days or a few weeks. So we know that this will be out in the literature relatively soon. And in this second paper, what we did, again, was looked at lots of different databases in the literature. We looked at everything we could find from CDC and from NIH. And also then looked at research articles that specifically addressed prevention and care interventions for black MSM. We included studies that were randomized controlled trials, that were experimental, but we also wanted to include other kinds of studies that were maybe quasi-experiments or non-experimental designs, as well as formative research. So we really wanted to look as far and wide as we could to find relevant literature. And on this slide, what you see is a little bit of a summary of how many titles we found. Actually, we started with about 4,000 titles just when you do all these searches. But as you take those thousands of titles and sort of narrow them down, what we really found was that at the end of the day, there were 23 studies that were most relevant. 16 articles, 12 were on efficacy studies, and 4 on formative research. And then 7 governmental study records that we found as well. And when we poured through those 23 studies, what we came across was that there were really 12 completed intervention studies for black MSM. And I think the number 12 is an important one to pause on for a moment. Given the incredible epidemic among black MSM and HIV in the US, the fact that there's only 12 completed studies is really an important thing to note in and of itself. We need much more research urgently. And of those 12 completed studies, 8 were aimed at interventions to reduce HIV-related risk behavior, so more prevention interventions, and were relatively intensive kinds of interventions. Some were individual one-on-one kinds of programs, some were more group or peer opinion leader kinds of interventions, but relatively intensive kind of services. And then 4 of those 12 were aimed at increasing use of HIV-related services, one in particular on HIV testing increase and the others on access to care and adherence. And then were also a few more formative studies and 7 more that we found that were ongoing and not yet completed at this time. And what I think we took away from this was that behavior change interventions have really been found to be effective at reducing HIV-related risk behavior. So we do have different kinds of programs that work, including programs for black men who have sex with men only, for black men who have sex with men and women, or black bisexual men, youth, young black gay men, and also persons who use drugs. So there is some diversity in these interventions in terms of population served. And then also, I should say, and this shouldn't be a sub-bullet, but should have been, I hit tab one too many times here. There was good evidence, I think, from the programs looking at access to testing and access to care, that some of those interventions also were successful as well, too, for helping increase utilization of services. So I think that we do have some programs. The issue is we don't have enough programs yet, but hopefully that it will continue to grow. Also, I think when we looked at this, given the intensity of some of the behavioral interventions, one of the things that we worried about a little bit in the paper was about the scalability of some of the more intensive behavioral interventions and how broadly they might be able to be used, given that they'd be a little bit more resource intensive. And also, again, we thought that there needed to be more studies to inform this evidence base regarding programming for HIV testing, linkages to care, and that we need to think a little bit more broadly. Given that there were only 4 such completed interventions, we'd like to see programs that go all the way from the individual to systems level change and community level change. So then the third and final paper that I wanted to mention, and I'll spend a little bit more time on this one, was looking at unmet needs for HIV services among black MSM in the US. And the purposes of this particular analysis was to help try and look at the scope of unmet needs for prevention care and housing services, to determine the costs of meeting those needs, to try and estimate the number of infections we might avert or how we might change the incidence curve in the US, and also what the return on investment or cost effectiveness might be. And I should say too that this particular study has been submitted for publication. We don't yet know the results of that review. So one preamble I would say is that the numbers that I'll present today are what we know best at this moment. Of course, during the process of review at the journal, maybe things might change, but this is our best estimate at the moment. So what did we try and do in terms of methods? Well, first we needed to estimate population size. So we wanted to try and estimate the number of black MSM in the US, and then focus on the number of black MSM living with HIV, and then break that down even further into persons who were undiagnosed, who had specific service delivery needs, who had suppressed or unsuppressed viral load, and who may or may not have engaged in unprotected risk behavior in serostatus discordant partnerships where virus was present. And we also wanted to look at the costs of unmet needs, so we would know what the price tag would be if somebody said, well, what's the unmet need here? What dollar cost are we talking about? And then we also wanted to estimate the cost effectiveness of meeting those needs. And so then I've got several slides here that talk about the results so far. So based on our best efforts, we think that approximately the number of black MSM living in the US is just a little under 736,000 men. This was based on the great work of Spencer Lieb and others who had previously looked at estimating in 2007 the number of 18 years old and older black gay men in the US. So we wanted to go back and adjust that for the years 2007 to 2011. And we also didn't want to leave out young black gay men 13 to 17 years old. So we wanted to make that adjustment as well. So if for 13 years old and older in 2011, this is our best estimate of population size. And then based on what we know about prevalence of HIV among black MSM, we think that our best estimate is that probably means that just a little over 195,000 black MSM are living with HIV in the United States. And if we break that out further, we think that among that 195,000 men, that just over 50,000 are living with HIV but not yet diagnosed. That just a little under 68,000 are living with HIV who are diagnosed but not yet linked to care. And then we think that there's about 19,500 approximately black MSM who may be diagnosed and engaged in unprotected risk behavior and serostatus discordant partnerships where virus is present. So there could be result in transmission. So if we apply then to those population numbers in needs of different kinds of services, and we apply the 2015 National HIV and AIDS Strategy goals, what do we get in terms of overall unmet need? Well, again, in the National HIV and AIDS Strategy, the goal by 2015 was that we'd achieve 90% awareness of seropositivity or 90% diagnosis rate, that we'd reduce incidence in the U.S. by 25%, and we'd reduce the transmission rate by 30%, and that about 85% of people living with HIV would be linked to care. Now, the wording is a little more precise than that in the National AIDS Strategy, but that's sort of approximately it. So what does that translate to? If we take those goals and apply them here, that would mean that we need, by 2015, to help just over 3,700 black MSM living with HIV in need of housing. The National AIDS Strategy goal says that about 21,800 more people who are living with HIV need to get into housing. So this would be a piece of that. Also that about 30,600 or so black MSM living with HIV who are not yet diagnosed would need to become diagnosed. That almost 72,000 black MSM living with HIV who have unmet care and treatment needs would need to get access to care. And then again, the behavioral prevention services and other prevention services for persons living with HIV might be useful for the approximately 19,500 people I mentioned earlier. So then if we take some of the epidemiology here, what do we know about the estimated number of new HIV infections among black MSM in the U.S.? Well, based on CDC's great work, we think that's about 10,800 new infections a year among black MSM. And what does that mean for the transmission rate? And by transmission rate, of course, I just mean we take the number of new infections in a year and divide it by prevalence, or take the number of new infections and divide it by number of people living with HIV. And what this means then for black MSM is that there'd be about 5.53 transmissions per 100 black MSM living with HIV to seronegative partners in a given year. That means that over 94% of black MSM are not transmitting to any partners in any given year. And also I should say that overall the transmission rate in the U.S. is about 4.2, 4.3. So this highlights again the heightened transmission rate for black MSM in the U.S. The other thing I should say quickly here, just as a caveat, is doing these calculations for this particular rate assumes that the partners of black MSM are other black MSM. And while that may be true to some extent, clearly is obviously not entirely true, but it's a simplifying assumption you have to make in order to do these calculations. So I want to say that that's a limitation of the work, and having better and more information about partners and social networks among black MSM and differences in race and ethnicities would be really helpful for furthering this kind of work. Also then, we can take that transmission rate and break it out a little further among persons who are aware or unaware that they're living with HIV. For persons who are living with HIV but not yet diagnosed, that transmission rate is about 11.5. And for persons who are aware, it's about 3.47. So huge differences in the transmission rate once somebody knows they're living with HIV. And that's twofold. One, it accounts for some of the treatment as prevention effect of being on treatment, but it also accounts for behavior change as well. So both behavioral and biological or biomedical factors are influenced there, are included there. And then the other thing to say is we can narrow down just to for persons who have any risk behavior, unprotected risk behavior in serodiscordant partnerships, and unsuppressed viral load. And we find a very high transmission rate in that case of almost 37. And I think that's an important thing to keep in mind because it shows us that we have both behavioral and biomedical pathways to address that one particular very high transmission rate. So then what are some of the more economic results here? Well, if you look at how many people need services, as we mentioned a couple of slides ago, it means that there's about $2.475 billion in unmet treatment, care, and prevention and housing needs for black MSM in the U.S. And I think that's a really important number. I don't think that estimate was previously available to us. And that could be in new money, it could be in redirected money, it could be in public sector, it could be in private sector. Lots of different ways to come to that, but it's a price tag on the overall amount of unmet needs. And we can break that out further. About 44.6 million would be for housing, about 362 million for diagnostic services or testing related services, about 2 billion in care and treatment services. Hopefully a fair amount of that might be covered under the Affordable Care Act, and 26.6 million for prevention services for persons living with HIV. And we can also do some mathematical modeling and say, based on those transmission rates I mentioned earlier, if we provided these services, how many of those 10,800 new infections a year might we prevent? And we think our best estimate is just over 6,200. That's well in advance of the 25% incidence reduction goal of the NHAS. So we really think if you make this kind of investment, you really could change the fundamental nature of the HIV epidemic among Black MSM in the U.S. And also, if we look at the return on investment, it comes out to be just over $20,000 per quality adjusted life year saved. And when we compare that $20,000 per quality adjusted life year saved to other kinds of public health and medical interventions like screening mammography or diabetes screening or kidney dialysis, it's a really good value. It's an incredibly good return on investment. So it would look very good compared to other medical and public health interventions. And then the other thing just to say is all the analysis I've presented so far use CDC's estimate that about 25.7% of Black MSM living with HIV in the U.S. have undiagnosed seropositivity. But if you look at the National Health Behavior Survey, the behavioral epidemiology work that CDC does, you actually get a much higher number than that, which would lead you to believe that roughly 50% of Black MSM who are living with HIV don't know it. And even if you adjust for possible over-reporting and self-reporting of prior knowledge of serostatus, that comes out to be about 43.5%. So instead of that 25.7% persons not knowing that they're living with HIV that we used in the base case, we also did some sensitivity analyses to use this higher number as well, too. If you use that higher number, the unmet need goes from about 2.5 billion to about 3.4 billion. The cost effectiveness ratio gets a little higher, but it still looks cost effective, and you would still avert a lot of the infections in the U.S. But I just wanted to mention that's an important point of uncertainty, and it's one that further research could be done on to try and hone in on that number. But I think for all of these things, it's also important to keep in mind that to have effective service delivery, all of the social determinants of health that we heard about earlier today must be addressed as well. You can't successfully provide treatment if you don't have housing, or you can't successfully provide treatment if you haven't addressed stigma and discrimination and homophobia. Those are very important issues to be addressed. And without that supportive context in place, it's really hard to address these unmet needs. So I just think overall in conclusion, we think that there does appear to be very substantial unmet HIV housing, care, and prevention needs among Black MSM in the U.S., that investments to meet those needs would be clearly substantial. However, they would fundamentally change the nature of the epidemic among Black gay men in the United States, and they have the potential for being a very cost-effective use of our resources. Also, I think that it's important to keep in mind that when the National AIDS Strategy was released in July 2010, the President said the question is not whether we know what to do, but whether we will do it. And I think having that in mind, that it's not so much a question of knowledge as it is a matter of will, is incredibly important. So thank you very much again for including me in this discussion.
Thank you, Dr. Holgrave. And now we move to the NMAC staff, to Collie Lindsey. I want to acknowledge the presence of the Chief Executive Officer of the National Minority AIDS Council. I see that Paul Kawada has arrived. Greetings, Paul. But now it's time for Collie to share his thoughts with us. Collie Lindsey is the Director of Legislative and Public Affairs at the National Minority AIDS Council, where he and his team work to promote sound policy to bring an end to the HIV/AIDS epidemic. They are particularly focused on thoughtful implementation of the Affordable Care Act and the National HIV/AIDS Strategy, and how it will end the epidemic in communities of color and all disproportionately affected populations. Prior to joining NMAC, Lindsey managed a federal policy portfolio for Harlem United Community AIDS Center, Inc., a federally qualified health center for homeless people in New York. It's an FQHC where he led efforts to improve access to preventive, interdisciplinary, and comprehensive health care for people suffering from multiple chronic conditions, often including HIV. Lindsey also served as the Vice President of Federal Government Affairs at the National Association of People with AIDS, NAPWA, and Lindsey completed his undergraduate work in psychology and communications at Eastern Michigan University in Ypsilanti, Michigan, and began his HIV career in 2003 as an HIV prevention and testing counselor in Detroit, Michigan, shortly after learning his own HIV diagnosis. He's also a friend. He's also the vice chair of the National Black Gay Men's Advocacy Coalition. And without further ado, Collie Lindsey.
Thank you, everybody. It's so good to see so many of your faces this morning. I want to again acknowledge Paul Kawada and Daniel Montoya for being here this morning. They are the Executive Director and Deputy Executive Director of National Minority AIDS Council. Without their support, we couldn't have made this work happen, so thank you again for being here this morning. I also wanted to take some time and immediately call attention to the road warriors that helped us really bring this project to life. So first, let's start by acknowledging our co-author, Ace Robinson, if you wouldn't mind standing up and stay standing. And keep standing. And I also want to call out the rest of the study panel. I see we have Robert Soto from the Serial Project, and by way of Louisiana, now in DC behind him. We also have Ernest Hopkins sitting here at the dais. He is also a member of our study panel. We have our good friends from the National Alliance of State and Territorial AIDS Directors, Isaiah Webster and Blake Rowley. And I thought I saw Kevin Jones. Did I? There he is. There's Kevin Jones from Metro Teen AIDS. There are more that hopefully you will get to meet, and we'll list their names for you at the end of the presentation, but without the partnership and hard work from these brothers, this project would not have been possible. And obviously, we have to acknowledge Brooke Kelly Green and the Ford Foundation for their incredible support of this work and for joining us for their launch event this morning. Thank you so much. So without further ado, as I said at the beginning, this is really a project that's the culmination of 3 years of work to both develop an action plan with recommendations to really move the conversation forward in addressing social determinants of health among Black gay men. In addition to making these recommendations, we also wanted to respond to the absolute dearth of information in the community about how to really improve sexual health outcomes, as well as how to address the many social determinants that permeate our existence on a daily basis. We're going to do that in a couple of different ways that I'm going to talk about during this presentation, but since you're on the first slide and you see these wonderful characters here at the top, we worked with an artist or a graphic designer to come up with these avatars as an illustration of individuals within our community. And you will note that Dr. Holgrave mentioned earlier in his talk that he switched to MSM because that's how they're referred to most in the literature. We made an active choice to refer to Black, gay, and bisexual men because all of the issues that we are going to talk about this morning happen within a context and a community, and we thought we needed to talk about those individuals within the communities that they exist within. So as you go through the presentation, you'll get to see more of these characters, and if you visit us at blackmenrise.org, you can even read their stories. But these are our community, and we're going to hopefully use them to tell more stories about what's going on in the Black gay community and hopefully excite some more action. So I have to start by picking up on the second word of the title that we chose for the report. The report is called Rise Proud. And in every issue or in every aspect of the Black community, not even just specifically the Black community, pride is always an important value. whether it's related to the fist pumping or the black pride or the Afro picks that we used to don in the early 60s and 70s, or if it's going into any restaurant that's owned by a minority individual, not just black community business owners locally or nationwide, and seeing a picture of President Obama there on the wall. Pride is an important element of all of our abilities to feel resilient and to move forward in the light of any opportunities that are ahead. And when President Obama said on World AIDS Day 2011 that when new infections among young black gay men increased by nearly 50% in 3 years, we need to do more to show that their lives matter. That was a watershed moment, I think, for so many of us in the black gay community. Not only did many of us not ever think that we would hear black gay men come out in a sentence from the President of the United States in an affirmative way, but it came out from the president that happens to look like us. So that means something to many of us, and we couldn't approach this work without acknowledging that. How did we get started in developing this project? Well, this story actually began a long time ago. In 2005, CDC released an MMWR looking at HIV testing behavior in 5 cities. And in 5 of those cities, they found in the prevalence of about 1,700 men, that there was 50% prevalence among the black gay men that were tested in that population. Those tests were done in Baltimore, Los Angeles, New York, San Francisco, and Miami, what we all know as many of the leading epicenters of the HIV epidemic in the United States. From that kind of battle cry, if you would, many grassroots efforts began to emerge or strengthen. It led to the development of what we've already talked about, the National Black Gay Men's Advocacy Coalition, as well as the Black Gay Men's Research Group. And later on, it would even give rise to the Young Black Gay Men's Leadership Initiative. Further, the research was continued because it wasn't sufficient that we heard the data from the 2006 MMWR. We needed to understand why there were significant disparities among black MSM versus, or black gay men versus their other gay counterparts. And Millett did a meta-analysis in 2006 which looked at a series of literature. We updated this same meta-analysis in our findings in looking further at social determinants. And the most significant thing that he found was that a lack of gay identity was not correlated with increased risk. So oftentimes I think when we're trying to talk to black gay men and black gay communities, we get hung up on identifiers. And what we found out in the literature, and what we continue to learn in the literature, is that we know that individuals that perhaps people like to call down lower, individuals that might be engaged in alternative lifestyles, that is not a risk behavior that's connoted with high HIV vulnerability. So we want to disabuse that conversation and finally do away with the conversation that it's down low individuals that are perpetuating epidemic. It's actually racism and social determinants that are. So we don't need to victimize or further pathologize black men or black male sexual behavior. We can just own that there are structural conditions in our community and our environment that we need to address, and we can move forward. We also learned from CDC in 2010 that HIV prevalence in the black community among black gay men is significantly pronounced and disproportionate. Black gay men are 40 times more likely to be HIV positive than African American women, though African American women are significantly impacted by the HIV epidemic and by far the most disproportionately impacted group among women. Black gay men are still 40 times more likely to have HIV than African American women, and 44 times more likely to have HIV than heterosexual men. And then finally, more recently, Dr. Prejean, who works with Dr. Jeffries at the CDC, put an article in PLOS ONE updating on the HIV surveillance report in 2010, which indicated that between the years of 2006 and 2009, HIV infections among young black gay men between the ages of 16 and 29 increased by 48%. Then that gave rise to our approach to this work. First, we wanted to acknowledge that research and practice heretofore has largely focused on sexual behavior and risk behavior. So we were interested in HIV testing rates, how many people use condoms, what the rate of diagnosis was. We weren't focusing on the contextual issues or the environmental dynamics that might have enhanced vulnerability among some gay men over others. And Dr. Stahl, as was mentioned earlier, has really been kind of a pioneer in giving us a language to really talk about these mutually reinforcing and overlapping epidemics. And Dr. Perry Hopkins has released a paper just this year that kind of reinforced this concept and talked about the importance of addressing syndemics if we're to address HIV among Black gay men. How he defines syndemics is HIV and other health problems overlap and fuel each other and create mutually reinforcing cluster of epidemics known as the syndemic that results in higher rates of HIV and AIDS. So if we're to move forward as a community in addressing HIV incidence and prevalence among Black gay men, we have to address these mutually reinforcing clusters of epidemics that perpetuate vulnerability. So this is our project. RISE was an action plan that was developed for two purposes. First of all, RISE stands for Resources to Improve, Strengthen, and Empower, and recognizing all of the presentations that have been offered today, we recognize that there's a significant amount of unmet needs, both in terms of literature resources, but also in terms of access to resources and services to meet healthcare needs. So we really wanted this project to both move the country forward in terms of resource allocation and service mix, but we also wanted to address many of the important information gaps that exist among Black gay men that helps them shape decisions that they make about their sexual behavior. So we wanted to complement and contextualize existing resilience work for Black gay men, recognizing that this isn't the beginning, and wanted to give credence and respect to a lot of the other work that's been done by Dr. Schall, Dr. Jeffries, and many other Black gay researchers and non-Black gay researchers alike. We wanted to complement and further contextualize that in a mechanism to excite action going forward. We also wanted to kind of drive the narrative and policy focus and resource allocation further upstream in the epidemic. Instead of just focusing on when people are coming into testing, engaging in care, and getting antiretroviral therapy or healthcare services for seropositivity, how can we drive our efforts further upstream and begin to address some of these contextual and environmental issues that enhance HIV vulnerability? And then finally, we wanted to address misinformation and the need for informative and accurate information among Black gay men. How we embarked upon this process, again, this was a 3-year labor of love. We started with the help of the Henny Group with some focus groups with HIV positive and HIV negative men in 3 cities throughout the country. We started in Atlanta, Georgia, New York, and then finally ended up in Oakland, California, and had one group of Black gay HIV positive men and one group of Black gay HIV negative men. In each of those groups, we asked questions about their understanding of the HIV epidemic, how to protect themselves from HIV, and their knowledge level about some of the new and emerging biomedical interventions to include treatment as prevention and pre-exposure prophylaxis. As Dr. Holgrave presented, we also did a systematic review of the literature and correlative data analysis. And then we also worked with our subject matter expert advisory panel. We met in person 4 times to discuss 3 different topics. We started with the LGBT community and dynamics within there. We talked about social determinants of health, and we also talked about contextual issues that we needed to address in the action plan that we developed. Finally, after a meeting, we reviewed all of the literature that was available, that which was developed through our project and the other universe of literature that was out there, provided feedback on the action plan that was being developed, and ultimately signed off and helped shape the recommendations that I'll articulate for you next. RISE Proud contextualizes our experience as Black gay men in 3 key domains. The first domain is the criminal justice system. Dr. Jeffries gave us a really important foundational understanding of the role that criminal justice plays in the lives of Black men, and our report will tackle that head on. We also heard from both Dr. Jeffries and Dr. Holgrave about the true nature of social determinants of health and the role that they play in driving HIV among Black gay men. And then we also began to talk about unmet needs at the end of Dr. Holgrave's presentation and what kind of structural barriers must be addressed if we are to improve engagement in healthcare and treatment among Black gay men. And finally, our recommendations will focus on key opportunities to have population-level impact among Black gay men and reduce HIV vulnerability. And most importantly, we hope that this plan will not just be a document to sit on the desk, but a community mobilization tool, that this will be the only beginning of many additional conversations and collaborations to pull government and non-governmental alike partners in rooms together to talk about how we could collaboratively move this work forward. In our section around the criminal justice system, to respond to a lot of the data that you heard about in earlier presentations, first and foremost, we recognize the harmful nature and the absolute unnecessary nature of HIV criminalization laws. While recognizing that HIV remains an infectious disease, and many of us remain very concerned about our risk to that disease, never in the history since the HIV criminalization laws have been put into place have they ever been demonstrated to prevent one infection of HIV. Instead, they are used to control behavior which never seems to be controlled and criminalize additional individuals and further stigmatize individuals living with HIV by making them seem like some exceptional risk or threat to humanity that must be protected with criminal prosecution. This is a significant barrier to sound public health. It's incredibly difficult to engage people in HIV testing, care, and treatment when they recognize that that very activity might open them up to potential criminal prosecution. They must be addressed. We also must do more to safeguard against discrimination among racial, ethnic, and sexual minorities. This is in multiple institutions as well as in our community. Some legislative maneuvers are being considered at Congress currently. Some things like the Employee Non-Discrimination and the Student Non-Discrimination Act are looking for ways to identify protections to help people just get access to employment or have equal access to just thriving in their educational environments without having to worry about anti-gay discrimination, abuse, or bullying. And we think that those are going to be incredibly important if we're going to address some of those unmet needs. We need to get these individuals educated and in stable and sound employment. We also understand the importance of providing comprehensive health services to inmates in prisons and persons reentering communities. For too long, there's been this ongoing obstruction or lack of willingness to address the fact that there is sexuality that occurs in prisons, that those individuals that leave those prison systems come back into communities, where whatever happens within those institutions that goes unaddressed will ultimately have an impact on the communities that they return to. That can't be happening for a community like the Black community who experiences so much mass incarceration. We absolutely have to make sure that we control the movement between incarceration systems and reentry into community, so we make sure that until we can adequately address the racism and discrimination that perpetuates mass incarceration, at least we can address health outcomes as they go inside and outside of the institution. And we also need to better educate our law enforcement officers within institutions and make sure that they understand the true nature of how HIV is transmitted. Many of our law enforcement officers still continue to perpetuate misinformation like HIV is transmitted through biting or spitting and other forms of non-transmitting behavior, and that ultimately leads to discrimination from other inmates and other staffs within the correctional institution. In fact, in some states, HIV-positive inmates are segregated from other inmates to keep their infectious disease under control and to further stigmatize them. We also have to create vocational opportunities among social networks to steer more people within the criminal justice system into care. You know, inmates are in these institutions for a variety of settings, and many of them have skills that can be immediately mobilized to address many of the unmet needs that we have in our community. The Affordable Care Act is rolling out, and there will be many opportunities to enhance access to health care, and we need to take advantage of the fact that there's this growing body of the strength of social networks to really engage people that can be outside of access or are difficult to reach for many of our efforts. We need to tap into that resource and make sure that we're using individuals within criminal justice social networks to make sure that they're taking advantage of the opportunities to enhance their health care as other communities are. We have to expand privacy rights, recognizing that many within the criminal justice system are getting health care in rooms with lots of other inmates right next to them, often only separated by a curtain, making it extremely difficult for them to have conversations about their HIV or other private information. Individuals with HIV need to be given private accommodations so they can actually have their health care needs met in an accurate and in an open fashion, and don't feel that they have to hide that and risk segregation or being stigmatized by their fellow inmates. And then finally, once we help individuals re-enter community, not only address their healthcare needs, but also address their housing, employment, and educational needs. It doesn't make any sense for individuals that have, quote unquote, been, you know, not reciprocated. What's the word that I'm looking for, Billy? Rehabilitated, thank you. For individuals that have been rehabilitated to have to go back out into community and not be able to find jobs, not be able to access housing, and not be able to improve their circumstances by getting additional post-secondary education. Now let's take a look at the social determinants of health. We've seen a lot of great work happen in our community recently. We've seen pastors come out, even as close as Maryland, in support of marriage equality, and that has eventually seen some changes in both the environment as well as in the communities in which we live. We have to do more as Black gay men and as a Black community to support those individuals that are stepping out in the same way that we're supporting our president for his affirmation of marriage equality. We have to support those individuals within our community that are doing work that is progressive to our goals, and make sure that we reinforce those efforts and make them more scalable, hopefully, so that more Black gay men will benefit from them. We also have to ensure the availability of gay, inclusive, and scientifically accurate comprehensive sex education. Earlier in the presentation, I talked about the number of HIV infections that are occurring among young Black gay men between the ages of 16 to 29. Waiting for those individuals to get outside of the school system or delaying education that can help them prevent HIV acquisition is unacceptable. We have to find ways to expand access to quality, age-appropriate, and sexually relevant sex education within our school system so that we can empower individuals with the kind of information they need to protect their sexual health. We need to also provide cultural learning opportunities for sexual health educators. We kind of stick the gym teachers in classrooms and expect them to have a comfortable language talking to people about sexuality and talking to them about gay identity and perhaps gender identity. We probably need to acknowledge that that's insufficient, and we need to do more to support our sexual health educators so they can actually impart that information that will help the individual students in their classrooms thrive and be well. And we also need to direct more resources and efforts to community building and physical and virtual networks, recognizing that each one teaches one. So the more that we're able to fortify an army of individuals that are empowered with accurate information, they're able to teach other people in their community and help them engage systems of care and services, the more expansive all of our efforts will be. We also recognize that we need to develop a metric to assess the effectiveness of sexual health education for sexual minorities. Currently, we have a lot of information that talks about access to HIV testing and other information, but we don't have any metrics to determine whether individuals understand how to have safe anal sex, or is all of their education just about safe vaginal sex? Do they understand the differential risk between oral sex and anal sex and other forms of protecting themselves or risk reduction that might not normally come up in the course of traditional sex education? So we need to develop metrics that make sure that the education that's being provided to our community members is actually helpful and effective for their actual lives. We need to enhance protections from discrimination in school and intimate partner violence. The It Gets Better campaign has told us a lot about the experiences of bullying and discrimination and harm that many of our students face in their school systems. It Gets Better and other social marketing campaigns, as well as legislation like Student Non-Discrimination Act, may very well be important steps forward in addressing some of these challenges, but we also need to do more to expand access to gay-straight alliances and other safe spaces within schools to ensure that individuals that are experiencing these circumstances have a safe space to turn to. And finally, the literature talks a lot about a lack of access to services for sexual minorities and incidences of domestic or intimate partner violence, oftentimes because those shelters are created for women, and oftentimes because law enforcement officers don't see same-sex relationships as, number one, valid or important to respond to. So individuals oftentimes feel locked within those violent relationships without resources to really get themselves out of those circumstances and find alternative housing or get into a safer space. We need to enhance those protections for those individuals so that their sexual health isn't compromised by violence within a relationship. And then we also need to increase service and shelter availability in the same way while addressing chronic housing and employment challenges among Black gay men. And finally, we wouldn't be the National Minority AIDS Council if we didn't talk about the structural and systemic barriers to accessing health care and treatment that must be addressed among Black gay men. One of the things we hope that HHS will focus on is really creating duty stations in high incidence areas in the South where the ACA may be stagnated. We had some really great information come out. RAND released a study to talk about the billions of dollars that will be left on the table if some states in the South don't expand Medicaid. We hope that they'll listen to that, and we'll be able to mount a defense and a strategy that will expand Medicaid and really try to enhance these goals through ACA, even in those other states. But if we don't do that, then the duty stations become another important way to address medically underserved populations through strategic use and placement of federally qualified health centers and medical services. We also want to increase interagency collaboration and planning to facilitate optimal ACA enrollment and resource allocation. A lot of great work has already been done through the HIV/AIDS strategy, and there's an interagency council that's already meeting regularly. And we believe that more improvement can be made on our fight against HIV in the Black gay community by looking at more ways to focus those efforts to look at the epidemic among Black gay men. We also recognize the need to increase understanding of employment protections to sustain access to care. You know, the reason that many of our partners in the GLBT community are supporting things like Employment Non-Discrimination Act is because in most places in the country it's still okay to fire someone because they're gay. And you don't have to provide an excuse for it, you don't have to provide a rationale for it. You can simply be ejected from your job and your economic security simply because you identify as being gay. And in the United States, employment is our primary route to accessing health insurance. So in an environment where employment is so key to our health outcomes, we have to do more to protect employment for sexual minorities that are at risk for HIV. And we must create vocational opportunities for inmate and exit offenders to facilitate ACA enrollment, as well as the healthcare services that we talked about in the social determinant section. Finally, we need to look at positioning better federally qualified health centers and behavioral centers, recognizing that some of the challenges that we talked about earlier deal with our emotional and psychological and mental health. And we need access to services that can remedy some of those challenges that we might be addressing in addition to our HIV vulnerability. And then, you know, recognize that for many of us, HIV might not be the worst thing that can happen to us. I just needed to stop there because the statement there is that for most people that are looking at resolving the HIV epidemic, if we can't first confront that the environment within which Black gay men oftentimes can be far more threatening and severe than the HIV epidemic, this conversation stops. But I'm seeing nodding heads, so I will move forward. The environment within which Black gay men must be addressed if we're going to adequately address the HIV epidemic, because for many of these men that experience acts of violence and feel besieged by anti-gay or anti-Black or even anti-male violence in the communities in which they live on a regular basis, we can't have a conversation with them about getting tested for HIV and into care. We have to address their contextual issues first. And we must direct resources toward the development of patient-centered medical homes that actually work for Black gay men. We've had a lot of efforts done recently to look at strengthening patient-centered medical home models. Some of those have focused on Black gay men, none of them have worked. And we need to do better at looking at what kinds of mechanisms, as Dr. Holgrave highlighted, would improve engagement in HIV testing linkage to care and retention in care to achieve viral suppression. And then finally, we must improve routine HIV and STI screening and sexual health assessments in all publicly funded clinics. Despite the fact that the Federal Bureau of Primary Health Care sees about 20 million people each year in their clinics, most of them impoverished and most of them on Medicaid, they did a whopping 800,000 HIV tests. 20 million, 800,000. And we already recognize the inextricable link poverty runs with the HIV epidemic. It's an incredible source of HIV diagnosis, and we need to do more to ramp up HIV screening and STI screening in federally qualified health centers, particularly with the support of the recent United States Preventive Services Task Force recommendation. And then finally, eliminate any barriers to essential healthcare services for racial, ethnic, and sexual minorities to assist them in accessing healthcare and antiretroviral treatment. Health insurance card will not be enough. We're going to continue to need the Ryan White Care Act, and we're going to continue to need other discretionary programs to address these contextual issues that we've been talking about and make sure that individuals that are experiencing challenges in their environment don't just have that additional challenge as a reason for them not accessing health care and benefiting from viral suppression. One of the things that we're talking about a lot in the HIV community is the future of the Ryan White Care Act. Fortunately, it does not have a sunset in 2009, so efforts with the Ryan White will hopefully be sustained, and we recognize the importance of resources and other resources like that continue to sustain the essential supportive services that are needed to keep people engaged in care. And now what we do with these recommendations. And that was just kind of an overview. I wanted to give you I didn't want to go in depth, so there's far more detail and language in each of the recommendations for you to dive into at your leisure. What we're going to do now that we've released the plan is a series of 4 steps. We're going to start with some community engagement sessions in 8 cities around the country. A couple more we're going to attach onto some conference participation. But our community engagement sessions, we're going to talk about the recommendations that we included in this report and highlight some ways that we can work collaboratively with community to begin to address some of the recommendations that were highlighted. We're going to go into Houston, New York, Oakland, Atlanta, Orlando, Detroit, Philadelphia, and Memphis. We wanted to get a good mix of urban versus semi-rural. There's nothing really rural there. We wanted to try to get around to as many diverse environments of Black gay men as we possibly could. And we're always looking to find additional opportunities for support to bring this effort into more communities. We're also going to be doing leadership training at the United States Conference on AIDS. And my colleague Tamara Combs is in the room. The National Minority AIDS Council has a program that's specifically designed for developing Black gay men, male leaders, and community-based organization called MILES. And we look forward to partnering with Tamara Combs and the MILES program in continuing to build leadership among Black gay men in the community. At the leadership training, we will not only talk about the capacity building available through the MILES program, but we'll also talk about the recommendations in the report and talk about how these Black gay men can help us mobilize these efforts in the community. And we also will organize a policy roundtable in Washington, D.C., where we'll bring national policy leaders together to discuss efforts to implement the National HIV/AIDS strategy and talk about any progress that we've achieved on any of the recommendations outlined in the plan. Finally, we have a website called blackmenrise.org, where we'll be inviting many peer opinion leaders to provide thought-leading excerpts and posts on the website to educate Black gay men both about community dynamics as well as how they impact the HIV epidemic. But we'll also be putting out special topic information like podcasts and whatnot on pre-exposure prophylaxis and other salient topics within the HIV response. And then finally, we'll offer multimedia downloads and sexual health comics so that people can download different entertainment and educational aspects to strengthen their information and resource base, as well as tell a different story in a way that's hopefully affirming and not overly identifying, so it has maximum accessibility once it's out in community. And finally, I would like to acknowledge all of the incredible people that put in the work. You've met many of them in the room. Some of them weren't able to make it here with us today, but all of these members were part of the RISE study panel that helped to strengthen and make the panel, the action plan which you see today. I also want to acknowledge the incredible work of the Legislative and Public Affairs staff, Kyle Murphy, my Assistant Director for Communications, Dan Nugent, and Ben Carter in the back for helping us pull this event together, as well as our returning intern and research assistant, Matthew Zofchek, who is on his way to Ohio State University Law School in the fall. So we appreciate his work and him coming to spend time with us and helping us with this project. And we also wanted to acknowledge the work and efforts of Ace Robinson as the RISE Proud Action Plan co-author. Again, it was all a labor of love. And then finally, we had several presenters that helped to provide information to shape this document, from Dr. Lewis Graham at the University of Michigan School of Public Health, who provided a lot of information on social determinants, Sharon Letman-Hicks from the National Black Justice Coalition, who talked a lot about LGBT issues in the Black community and Black LGBT issues, Aisha Moody Mills at the Center for American Progress, who released a very incredible and salient report about HIV and among Black gay individuals. And finally, Dylan Orr from the Department of Labor, who talked a lot about vocational opportunities and employment statistics in the Black community and how those relate to HIV vulnerability. We hope you all will stay with us, continue to come back for more information about what we're doing to carry out the action plan recommendations. We hope that you'll visit the Sexual and Social Health Hub to see what kind of exciting posts and information we're going to put out there on the website. Please share it with your networks. We hope to drive as much traffic there as possible. And please give us your feedback as well, because we want to continuously develop that and make it a more meaningful resource for the community. You can also follow us on Twitter at @BlackmenRise, or you can email if you have any thoughts, recommendations, or concerns. Thanks so much for your time, and I look forward to answering any questions.
So those were amazing presentations. It's a very, very wonderful report, and I think, as Colleen mentioned, we hope it spurs a lot of debate and dialogue across the country. I want to just say a couple of things sort of in my San Francisco AIDS Foundation hat. I've been working there for a long time, since 1997, and I've also acknowledged on many occasions that while the epidemic in San Francisco is predominantly white and gay, they have always held fast to a commitment to ending the epidemic across the board and allowed me to follow the evidence. And so in many, many instances in the work that I do at the federal level, I am working on issues that are first and foremost focused in the Black, gay, and bisexual community. And so back in 2005, when that mortality and morbidity report was released by the CDC, and a group of Black gay men came together, some of whom are in the room, and said, what are we going to do? And the CDC looked at us with confusion, as if it was not their responsibility to actually have a response. It really made us angry. And I think many, many things that of value in this country have come about because people were just really furious at a lack of response. I think we can acknowledge that. And I think the National Black Gay Men's Advocacy Coalition came out of that. A number of things that Cully referenced in his statements came out of that. But I think it's important to think back even that far back, 2005. And then we could also go all the way back to the early, the late 80s and the early 90s when Black gay men really started doing prevention work in this country, to say what has changed. And what I would say that has changed is it's a mixed bag. Back in 2005, when we were dealing with the CDC and they finally had a consultation for us in August of that year, we had a pretty robust group of Black gay organizations that were prepared to respond to the epidemic. A number of those organizations no longer exist. And the few that do still exist, we are going to have to work very hard to sustain. Fast forward to the Obama administration coming in 2009 with a strong commitment to creating a national HIV/AIDS strategy, which has actually given the federal government permission to follow the evidence for the first time and to actually repurpose and redirect resources and to reframe policies to have them focus where the epidemic is now occurring. That kind of energy is now catalyzing report after report, research piece after research piece, which have been articulated here today and which actually are going to be the foundation of the work that we move forward. We now have the tools not only to end the epidemic, but to improve the health and wellness of Black gay men in the context of HIV. We know we do. And I think this report, the work that we do together in all of the organizations that we represent, is really going to take the kind of collaboration and partnership that the strategy calls for. It's not just the government's responsibility. All of us will have to come together to figure out what to do. These social determinants of health are long-standing, they're systemic, and they are unfortunately not easily resolved. And I think that when you acknowledge how challenging it is to turn that battleship around on some of these social determinants, you understand what we're actually facing. And so I really have to acknowledge the Ford Foundation and really thank them for the resources that were made available to make this report possible, and the process, not only the past process that created the report, but the process moving forward where the National Minority AIDS Council will be going out into the communities and having these dialogues and working with public health and working with community-based organizations to actually shift the conversation in ways that it needs to shift in order to improve the status the health status of black gay men. The numbers are unacceptable, but they didn't just become unacceptable. They've been unacceptable for a long time. What has changed is our commitment to shift the paradigm. Our statement to both ourselves and to government that it will not continue in the way that it has, and that we are committed to being a part of change. And so with that, I really want to thank you all for being here today, and to look very carefully at the information that's going to continue to come out on the National Minority AIDS Council's website. I love the avatars. I can't wait for the stories. There are some really rich, interesting stories that are available to us if we just listen to the young black gay men across the country who are out and proud at rates higher than ever and at ages younger than ever. And I think we all had something to do with that by creating things like Black Gay Pride, and I want to talk about Noah's Ark, and I want to talk about some of the other things that have been out there that have really given people permission to claim themselves. And now it's our responsibility to make it a safe environment for them to do that, to do it in its fullness so that they can have a happy, healthy sexual life and be productive citizens of these United States of America. And so with that, thank you very much for coming.
So we have some time for a question and answer for if you have any questions following up on Dr. Jeffries or Dr. Holtgrave's presentations, or any other questions about that action plan or steps forward. If you have any questions, please step up to the mic.
I have a question about mass incarceration. Have you guys considered or thought about taking a stance on some of those larger mass incarceration issues, like some jurisdictions have changed like possession of like marijuana from a criminal offense to a civil offense, or three-strike laws like in California? Have you guys considered those? I know that might seem a little bit outside of the HIV purview, but it's definitely right in the center of the camp of mass incarceration.
That's a brilliant question, Nathan, and we did speak to a lot of those challenges in communities, and we're going to actively try to take many of those on, to include things like stop and frisk that have occurred in New York City, as well as using condoms as evidence of sex work or prostitution. And we also hope to tackle, of course, some of the criminalization injustices around possession of marijuana, and we actually highlight the recent success in adjusting the sentences around powder cocaine versus rock cocaine, or cocaine, crack cocaine. So those are all issues that we hope to tackle within the criminal justice work, and as many opportunities for collaboration and efforts to impact some of those issues. We're willing to take those on. Thanks. Other questions? Were we that thorough in presenting?
Pretty thorough.
That's fantastic. That's fantastic. Well, thank you all again for coming, and please continue to stay connected.